Hi Jay, how are you?
I'm good. How are you doing?
So Jay, I'm Dr. Joseph. I am going to be taking over for Dr. Rodriguez. Do you mind if I use the audio assistant for our chat today?
If you use the what?
An audio assistant, it's artificial intelligence. It listens to our conversation and helps me with our notes.
No, not at all.
So, my friend, you are seeing me for a new cancer of your tonsil, um, and Dr. Rodriguez is fantastic, and she probably went over everything with you. But I just want to check in with you and kind of see, just give me a history as to how you found it, what's been going on, what do you understand about what we're dealing with right now.
Okay, well, at the beginning I was shaving, recognized I had something that was a lump right there. Shortly after, recognized I had a bump on the inside and went to an ear, nose, and throat doctor. At first, actually had a tooth pulled at a dentist somewhere in that process before, and the dentist looked at it and said the same thing, said, you need to see somebody about that.
Hmm.
And so they diagnosed it, took the biopsy, diagnosed it, squamous cell carcinoma, HPV positive, and then I've been on the track of tests and PET scans and CRTs and so on. Not CRTs, what the hell is it? CT scans and so on down the road.
Hmm.
Um, and my experience, I'm a little bit concerned because there's been some lag time, and I don't know what's normal. But I feel like I'm starting to notice it more.
Okay.
And so when I first went down to Seattle at Fred Hutch, I talked to the surgeon and the radiation therapist and the medical oncologist was called away for jury duty, which kind of blew my mind. So I'm like, okay, so it's going to be delayed because of that. And a week later, I was able to go down there and meet with her, but I feel like it kind of staggered the whole process a little bit. I just don't know. As I say, in the last couple of weeks, I've noticed there's something going. It's just a little bit. There's a little pain involved where there never used to be, and
Hmm.
it's just it's a little bit more obvious to me that it's there, and so it's got me concerned about whether it's growing. Well, of course it's growing, but I don't know how much and all that good stuff.
Right. Okay. Have you been having any other symptoms associated with this? Like, are you having difficulty swallowing? Are you having any infections that are associated with it or pain?
As I say, a slight noticeability of pain that just wasn't there earlier on in this process, and I'm aware of its existence 24/7. So it just didn't used to be the case. But beyond that, there's no real pain, and I put it at 0.5%, and kind of a non-issue, and no problem swallowing or singing karaoke or any of those kinds of things.
Okay. Okay, good. What do you understand about the disease itself? I mean, it sounds like, it's growing and that's a concern, but what do you understand about HPV
Well,
associated
it's my understanding that that its foundation is in some sexually transmitted disease that perhaps, I don't know, 80% of us carry around with us. And beyond that, I'm not really sure, what prompted it to surface on my tonsil. I've heard rumors that stress can be one of those things, but beyond that, that's really all I know.
So HPV can be a sexually associated virus, but it's also a virus that we can get from almost anywhere. And most people will get HPV at some point. Um, when it's sexually associated, it tends to be more of the cervical cancers and penile cancers that
Okay.
we get more concerned of. A head and neck cancer it could be related to that. It could also just, have occurred from acquiring
Yeah.
HPV. These what the purpose of knowing about HPV in this setting, however, is the fact that it tends to have a better prognosis than the patients who have HPV negative head and neck cancers.
Have read that. I've got there was a point in this whole process where we were waiting for the results to come back, and I had researched the hell out of them. I own a computer store, so AI is something I deal with every day, and you
Right.
can bet I have researched it up and down, and was very relieved to have it come back HPV positive.
Right. Right. And so this is a good prognosis. We know that treating it with chemotherapy and radiation would be effective. If this was the disease that was only localized in the neck or only in that tonsil area and nowhere else, then the possibility of just doing radiation would have been a reasonable thing.
Right.
We know that there's a lymph node involved here, and because the lymph node is involved, doing the combination of chemotherapy and radiation gets a better chance of knocking this thing out and making sure it stays gone. Okay. The way I look at it is that chemo is the jab to the radiation's hook. The radiation is the big player here.
Yeah.
This treatment is a tough treatment to go through, Jay. I'm not going to sugarcoat it. And it's not because of
Which part are you talking about? The both of them together?
both of them together. It's not an easy treatment to go through, and it's not because of the drug or the radiation. It's because of the location of the tumor itself. You know, everything goes through here, right? So you have your nerves, you have your blood vessels, and you have your ability to eat. That's all coming right through here. And you know, when we do treatment, you are going to lose weight. It's going to become a lot more difficult to swallow. Preserving your swallow function is so integral to going forward with treatment. Have you met with the speech pathology team?
I've met with yeah, Bailey once down in at Sloan 1, I think it was, Sloan 2, I'm not
Yeah,
sure which, and then I'll meet her again tomorrow sometime.
perfect. Working with the speech pathology team is huge, and maintaining your swallow function is huge for this treatment to be effective because the last thing we want to do, uh, the recovery from this is the hard part. Treatment is hard, but it's the recovery that's even harder. And the ability to keep you up with your swallow function, keep active, keep your hydration going. The more you're able to do that as we're going through treatment, the more likely you're going to make it through treatment and you're going to recover faster. My patients who take a long time to recover are the ones who struggle. They can't keep they lose their swallow function. Now all of a sudden we have a tube being placed to keep them going. All of that becomes a big problem, right? So the supportive measures here are going to be important. Working with our nutritionist, that's also going to be really important for your overall health and care. Okay. Um, Dr. Rodriguez talked to you about cisplatin chemotherapy. Cisplatin chemotherapy is the mainstay of treatment for this disease with the radiation. And it's chemotherapy that's kind of consistent with like what we remember from like 1980s, 1970s kind of chemotherapy. It causes significant nausea. It will cause you to lose your hair. It can cause you to have hearing issues and to like potentially have ringing in your ears or potentially even lose your hearing altogether. So keeping an eye on those symptoms are going to be really important as we go through treatment. This is a chemotherapy that causes severe nausea. Go ahead.
Christina at the time had thought that she had me down for three chemo treatments,
Mhm.
beginning, middle, and end. Is that your prognosis or is that different?
Yeah, so the cisplatin chemotherapy can be given in two ways. You can either do a weekly dosing or the every 3 week dosing, and they're equivalent in terms of their efficacy. A lot of times with my older patients or infirm patients, I opt to do the weekly dosing because it's just easier for patients from the perspective of like just getting treatment coming in on a more regular basis and not getting such a big dose. She felt comfortable with the 100 milligram dosage. I don't see a reason why we shouldn't be able to do that, which is the higher dose. You still come into clinic on a weekly basis, but you're getting fluids to kind of make sure that things are being kept up on the days that you're not getting your chemo. So you would get two chemotherapy treatments for sure. The third chemo really comes down to what's going on from a radiation perspective. So you should get chemotherapy for the period of time that you're on radiation. If you're able to finish radiation early, if, radiation gets curtailed for any reason, then I might say, hey, no need to do the last cycle of chemo. If there's like 1 day of radiation left on the day that you're supposed to do chemo, I'm going to tell you, hey, there's no advantage to doing that third treatment of chemo. Likewise, let's say for whatever reason, you start chemotherapy and radiation, and now the machine is broken for 2 weeks, and you're going to get radiation later. That might mean that you get a fourth cycle of chemotherapy, right? Because the idea here is
The
that
machine breaks. I didn't. hadn't considered that possibility.
It's not something that we expect to happen, but I'm saying,
Right.
can things happen? Yeah, things can
Yeah.
happen.
Yeah.
They're expensive machines and they need repair. They don't tend to go out for more than like a 24-hour period if they do go out, but things happen. And I'm
Yeah.
just giving you the idea that like if something were to happen, or let's say that you were in the hospital because of some side effect and you didn't get the radiation for a week, we might end up adding treatment at the
That's it.
tail end, depending on what's going on. That's ultimately what it comes down to.
All right.
Um, I will give you information about the cisplatin chemotherapy in the paperwork that I'm going to give you with with your checkout paperwork for today.
Okay.
And we're going to start the cisplatin chemotherapy within 24 hours of starting radiation. This is a chemotherapy that I can give you through an IV. There's no major issue with it. However, I do recommend ports in this situation because if you get really dehydrated or if you're not eating well, a port is going to be a much easier way to get access and give you fluids and make sure that you're doing okay. We can start without a port if you would prefer not to have a port placed.
Explain to
But
me what I mean. I've had my girlfriend's gone through cancer and she had a port put in. It sounded pretty damn invasive. I think they ended up putting hers in a jugular or something like that.
it is. So it gets done. It's not a surgical procedure. It just happens right over here in our interventional radiology suite. They're going to make like a small cut here under the skin, but on top of the bones on your chest wall. They're going to slip in a little bubble with the metal back on it, and that's the port itself. They're going to take a catheter, just like they would put in like for an IV, that plastic piece that sits. They're going to snake that under your skin into the neck vein up here, and they're going to insert it into your neck vein up here, and it's going to go down to your heart. This allows us to give you chemotherapy or any other treatment like very safely, always have access. We don't have to keep putting IVs in to get access to try and find something. We can draw blood from it. And like I said, with this kind of a treatment, there's a high chance that you get dehydrated, that your veins collapse, that you're really nauseous, you need treatment quickly. If you can't get an IV, it's hard, right? And that's what it comes down to. Do patients go through treatment without ports? Yeah, they do. And a lot of them can do just fine. But in general, I find that the port is very helpful here. So it's something I would recommend if you're willing to consider it.
Well, I don't. I'm not in love with the idea, but not. As far as the IV thing, you mind if I just do a little bit of research on that one?
For sure. I'll give you some information about it. I'll give you some information about ports as well. But what we can
But
do
I'm
is,
certainly going to consider it. Whatever is most advantageous for my recovery is what's most important, and I'll be looking into that.
yeah. And like I said, we can start without doing it and then come back around and consider doing it later if we needed to. That's not an issue, right? Um, so we covered those things. We would start treatment within about a couple of days of starting within 24 hours of doing the radiation.
Do you have any idea when this beginning actually is?
So the treatment is all going to come down to when Dr. Rivera has you set up to start radiation. I am going to get you set up as quickly as possible. It sounds like you have your simulation scheduled for tomorrow, correct?
Right. Yeah.
So once he does the simulation within like a week or so, depending on how everything gets scheduled out, they're ready to start the radiation. We will get the chemotherapy expedited, and we can start treatment as soon as they're ready to do the radiation.
Okay. Super.
Now, you had a thyroid mass that was biopsied, right?
Yeah, I did have an FNA done on that, and they just, they couldn't make anything of it, which I understand is often the case with those.
Yeah.
So it's an inconclusive thing. It's you can see it on the CT scan. It's a gray mass instead of a nice clear one.
Yeah.
But they don't think that it's related to the other, but they don't know. They just really can't really be sure.
And the biopsy was done up in Skagit or down here?
Yeah, in Skagit. Yeah, Skagit Healthcare.
Do you mind if we try to do the biopsy?
Actually, it was done at Island Hospital, yeah, in Skagit County.
Island Hospital. Do you mind if we try to do the biopsy down here? Because that's a pretty big mass. I want to make sure that we are
Yeah,
on
sure.
point here.
No, absolutely. If you, it would be great if anybody could figure it out before it turns into something else.
Yeah, yeah, I'm with you on that.
By the way, I saw a video of yours. I was poking around online. You got one floating around out there. I think it was a previous employer or something.
Yeah, it was when I was the med director at Multicare. That's from that video. Hopefully that's okay.
Oh yeah, you came across real well, actually,
I appreciate
and it gave me a better feeling about you.
I appreciate
You should
that.
start your own channel.
That I've never heard before. Maybe I don't know how my kids would feel about it, but
Oh, they'd love it.
um, perfect. So we will work on getting that set up. And I'm going to make sure that we get you set up to see our nutrition team as well. What I'm going to do, Jay, is I'm going to give you the information on the cisplatin chemotherapy. I'm going to see you the week after you get your chemo to do a toxicity evaluation. We'll make some medication adjustments based on that.
Okay, so you're not involved in the process of giving me my chemo. You just keep an eye on what's happening.
My nurses are the ones who will give you the chemotherapy. I'm the one who orders. Yeah. What I'm going to do is I'm going to send some anti-nausea medications into the pharmacy. I sent it to the Walgreens in Anacortes.
Yep.
You can go ahead and pick that up. You'll meet with my pharmacy team to do a treatment teach where they're going to go over the medications with you again and tell you when to take all the different medications. We'll regroup 1 week after, like I said, and go from there.
Okay.
I'm asking this question not because I think anything bad is going to happen to you, but because I ask this of all my patients I'm going to give chemo to. So if your heart stops, Jay, or if you can't breathe, am I doing CPR? Am I putting you on a machine to help you breathe? This is not talking about long term. We're just talking about in the moment.
Yeah, for sure.
Okay. Who makes medical decisions for you if you can't make a decision for yourself?
Boy, I have to make a choice on that. I've got my partner, Tracy, who is a physician herself.
Tracy Burgess?
Yeah, Tracy Burgess.
Okay, that's your partner. Somebody put Tracy in as your son. Let me change
As
that.
my son? Oh no, yeah, no. She's my life partner. We've been together for 7 years or so.
So Tracy is your partner, and Douglas
And Douglas is my
and
son.
Dave are your sons, and Joseph is your brother.
Yeah.
Sorry. Okay.
And I would say it will probably be between Tracy and Joseph. I had not considered. That's an interesting question and one that bears a fair amount of responsibility. Who gets the right to say pull the plug? Is that what I'm getting?
So there are a couple of things that happen with it.
Which it's not my world. You see it, and I don't. Yeah.
Yeah, so this is ultimately you're spot on in terms of where we're going with this conversation. So we're about to do some big things, right? And I don't think there's anything bad that's going to happen. I think that it's going to be tough, but I think we're going to get you through treatment. But life is full of surprises, and we don't know what could happen, right? You could get a bad infection with treatment. You could have an accident on the drive over, right? And you're in a car accident. You could have a heart attack that you were going to have regardless of treatment. And so as we're going forward with this, being very clear and deliberative of like who makes medical decisions for you, who make what decisions do you want them to make, right? Like this is something called advanced care planning, where you're defining it out because these are not easy. If we're asking Tracy to make those decisions, and Tracy should be grieving for you in that situation.
Yeah, yeah.
But and you said Tracy's a physician, right?
She is. Yeah, she's a hospitalist.
So if you talk to her about this, she'll know exactly what we're talking about and what to do. So it's saying like, hey, putting down, if I'm on a machine, you can keep me on a machine for 2 days, 2 weeks, 2 years. Never take me off the machine.
Right.
I'm okay with dialysis. I'm not okay with dialysis, or I want food through a tube. If you define everything out,
Right.
then it becomes easier for Tracy or your brother or your sons to make the decision. Likewise, you have a fair amount of family here. What happens if the situation is such that you've talked to Tracy and Tracy's the one making decisions for you, and Tracy knows you don't want to be on a machine more than 1 week. Now your son walks in, your son's like, no, that's not what dad ever said. Dad, we got to keep dad going forever. If it's in writing, now it becomes a lot easier for Tracy to say, no, guys, like we talked about it. Here it is. It's in writing. This is what he wants. Now everybody's on focused and on the same page rather than
Right.
fighting it.
Yeah. No, I can see that could get ugly, of
Um,
course.
and then you want to make sure that, you've decided who makes, financial decisions in this situation, who makes medical decisions. And they can be the same person if you want them to be. They can be different people if you want them to be. That's got to be your call.
Right.
So I'll put information about advanced care planning in here as well, but it's something that you should definitely consider doing.
Is there a
Okay.
statistic on people that are getting chemo and radiation that, or is either one? I can see where chemo would be a bit of a contributing factor because it's going through every cell in your body. Is that a thing?
In terms of how
Chemo relating to heart attacks? Is there a relationship there?
there isn't so much a relationship there. Cisplatin chemotherapy can put like a fluid load on the body that causes high blood pressure, and that high blood pressure can cause strain on the heart and things like that. But chemotherapy on its own would not be an issue.
Okay.
Yeah, good question.
Yeah.
Question. What other questions do you have for me?
Um, I don't guess I do. Mainly, you said I'm going to be talking to a nutritionist at some point in this. I think maybe that's tomorrow. I don't even remember. But that'll be something that I need, so that they give me and we can work together on what that's going to look like and what it needs to be. Yeah.
Feedback.
And no, I think that covers it. Yeah. It's always so. These conversations are very sobering, as you could well
Yes.
imagine. Yeah.
Yes.
I feel, I feel strong, just, for the record.
Yeah.
I'm still capable of running and so the time will tell how that works. But yeah, I don't feel like, no joint issues, no physical issues of any kind. So other than what's going on there.
Right.
So
Right.
hopefully that'll,
And I want to keep you there, my friend.
yeah, yeah.
Um, I hear a distinct Northeast accent.
Massachusetts, yeah,
Massachusetts. There we go.
yeah.
Okay.
I've,
I trained
FYI,
in Philly and New York, so
you what?
I trained in Philadelphia and New
Oh,
York.
okay, all right. I wanted to let you know I've got in case you ever want to weigh in, because you'll be in it at some point. YouTube, I've got a YouTube channel at jlapour.com, my name.
Oh, okay.
And just simply because of my tech savvy, I'm just in this stuff up to my eyeballs, puts me in a position to create content that would be of some value to other people that are going through these same types of things from the beginning of the process straight up until the time it's over. So
Right.
we've got the CAT scans in there. I'll have the PET scans in there. I'll have, whatever the hell it is, it'll be there.
It's important. It's important. And every little bit helps the next person. So I'm with
It's a
you.
little
So
cathartic, it's like talking to a shrink, even though you're telling it to the camera, and it helps knowing that you're being helpful to somebody else down the road too.
for sure. For sure. Yeah, without a doubt. What other questions do you have for me, my friend?
I can't think of anything. I'm just, I'm interested in, I guess, getting the party started as soon as possible, and that's in Dr. Riviera's hands. So I'll see him tomorrow, and I'm grateful for your call and the conversation, and
Sure.
some of the things you brought up is rather sobering, but they needed to be brought up. So that's reality.
Talk to Tracy about it, and we'll go from there. And I'll put some information about advanced care planning in the paperwork for you today as well. Okay.
Sounds good. Thank you. Oh, I have a question. Is there any possibility at all that you provide a copy of this recording for the patient to reflect upon or share with others?
So I'm okay with us recording conversations if you want to record in the future. The recording that I have is actually not something I get. It just transcribes everything into the note so that it says, "Hey, this is what we talked about." There's no actual recording that I hold on to.
Gotcha.
So,
Okay.
but then when you come in to see me next, if you want to record the conversation, I'm okay with that.
Audio's okay.
Audio.
That's great. All right. Super.
Okay.
Thank you very much. Appreciate your time, and we'll.
I'll see you in a couple weeks.
Okay. Bye bye.
Okay.